here. Good evening. Good evening. So, the long awaited webinar is here already, and it's time for us to get to learn so many things. So, please, I want you to get your writing materials. I want you to write. I want you to note things down. So for me to know that you are really here with us, please can you drop something in the comment section? You can type, please go to your comment section, drop an emoji, drop excited. Let's know that you are really excited to be here. I just drop something. Let's know that you are really here with us. Um so yes. Yes, let's do that. Let's do that. I'm Adebayo calling me Catherine. I'm from Excited. I'm representing Excited this evening. And I'm a medical student, I'm a 600 level medical student, and I will be one of your moderators. So thank you for joining in, like I said earlier. So our second moderator is going to be introducing herself now. So Dr. Jegere, please can you introduce yourself?
Okay, good evening, everyone. You're welcome to the program. My name is Ifeoluwa Kishi Jegede. I'm also a 400 level medical student. I'm representing Ekiti State University, the Health Awareness Club, Ekiti State University. I'll be the second moderator. You're all welcome, and trust me, you'll enjoy the program. Welcome,
Yeah.
everybody.
Yes, you are welcome. You are welcome. You are going to enjoy this program. So the excited representative to they have something for us. They have something to say. So can our excited representative come up?
Everyone. My name is Yanu
Good evening,
Bankole,
sir.
one of the members of the Excited team, and I'm glad to have all of you here on this webinar. What is Excited? What is the team all about? Okay, other than just talking about breast cancer because it is October, which is the Breast Cancer Awareness Month. Your interests align with ours, and so you can also join us and be a part of the team. So Excited is we are a team of young people who are aimed at merging health and entertainment seamlessly and just for one goal: to pass health information across without any hindrances. Now, our team is striving to achieve for the entire Nigerian populace is to be able to get health information across and make it accessible without any barriers, either language, you know, you have to have a lot of data, you have to know a lot of people and all of that. None of that, no barriers at all. To ultimately be one of the leading health media company in Nigeria and beyond, maybe in a few more years, beyond Nigeria, and then change the way people engage with health information. Because we know that our best bet to actually reaching all of Nigeria is through all of you who are on this webinar right now. So it means if you can get across to you, then we can be sure that you will get across to your brothers, sisters, fathers, mothers, and everybody around you. And little by little, you know how a single drop over time makes an ocean. Little by little, we can get to everyone. Hope that whenever you hear the word excited, just think of two things: creativity and excellence. So when you think of those two things, you would always remember that excited starts with health. So it means whatever we are doing, we are starting off from health information, everything that relates to health, but the ultimate goal is to be creative with it and to pass across all this information with excellence and creativity.
Thank you very much, sir, for that. That's Dr. Iyanu that just spoke to us. And he did mention something. He said, excited is about what? Creativity. First remember the aids in front of it. So we want to give you the aids content in ways that you would understand and you'll be able to make use of. And he also talked about the fact that we are creative and we want excellence even for everybody. So I'm sure that we've been following. Please, I want to really know if you are following. Can you drop something again on the comment section? Let's know, did you even understand what he said about excited, or you are just happy to be here? Please drop something. Um Yes. Just before today, and we've been able to get very very knowledgeable speakers, very knowledgeable people to teach us concerning breast cancer. I'm telling you, they are the best people you can ever have to teach you this topic. Really, they are the best people you can ever have. And so um before I to proceed, I'm going to be talking about our first speaker for today, in person of Dr. Omobolaji Ayodipo. Yes, he's a breast surgeon in University College Hospital UCH. Yes, the first and the best. And that is the first federal hospital you have here in Nigeria. And he has been practicing for years, and we are blessed to have him. Even both the students, his patients, we are very blessed to have him. I'm telling you, you will see in front of his consulting room, a lot of women are actually waiting for him to see them, and he's going to be sharing his wealth of knowledge with us. So please, like I said before, I want you to get your jotters. I want you to get your notepad. Please jot down things. Please note down things. Write down your questions. Anything you are not clear on, please note them down so that you will be able to clear all these. So sir, we can have you now, sir. Dr. Anyodipo, sir.
Hello, can you hear me?
Yes, sir, we can.
Yes,
Yes,
sir, we
sir,
can.
we
We can
can.
hear you, sir.
Can you see the slides now?
Yes, we can, sir.
We can see the slide.
So my remit is to give the audience a little bit of talk about the importance of detecting breast cancer early and how it impacts on outcome of the patients. And we need to remember that, like she's introduced me, I work in University College Hospital Ibadan and then University of Ibadan. Um, my academic interest lies in breast cancer and breast cancer outcomes. So I'll go straight into the lecture. Outcomes differ in terms of stage and presentation of disease. Some patients that present very late, the only outcome they want is quiet, solitude, no noise, no pain, circumstance till demise. Early patients' outcome will be I want to survive and live beyond diagnosis and treatment of this disease. So the metrics for gauging outcomes for patients differs across stage of presentation. Um, the introduction to all of this is that we know that breast cancer is one of the most important maladies that afflicts women now, and is the commonest form of malignancy worldwide for women. It's also been found to be the leading cause of cancer mortality, the second leading cause of cancer mortality in women. And rough estimates suggest that one of every 8 women will develop breast cancer in their lifetime. And the treatment spectrum is individualized across patients and circumstance and stage of disease now. And treatment spectrum includes options include surgery, chemotherapy, surgery, immunotherapy, hormonal therapy, and radiotherapy. And there are a lot of surgical options. Talking about my own specialty. In Africa, breast cancer is the leading cancer in women, and its burden has been on the rise in the last 3 decades because of longevity. Longevity. People survive more now from teenage years to adulthood, and even the elderly patients, because of the improved quality of life across health parameters, socioeconomic status, more people get to survive in Africa. Um, at the end of the 70s, life expectancy in Africa, sub-Saharan Africa, was 46, but in recent times, it's gone as high as 55, 56 life expectancy. And with an improved life expectancy, more disease afflicted patients will then survive, and then we have quite a number of patients that have this disease. Westernization of lifestyle characterized by delayed marriage, a shorter period of breastfeeding, and lower age at menarche are all factors that also summate to increase the risk of breast cancer occurring in women. And all of this was not so important or common in the early years of medicine in sub-Saharan Africa. But in recent times, because of westernization, they all come into play generally now. Mortality rates in Africa still are higher, and the survival rates are lower when you compare to developing countries because of poor oncology care. We're battling with infectious diseases, the malarias, the polios, the retroviral, the HIV, AIDS syndrome, a lot of hepatitis issues. We're battling with the infective things. So nobody has time for the chronic diseases yet. And when there's little fund available for health, it usually goes for to the infectious circumstances. So there's poor oncologic attention and poor oncology care across the spectrum of prevention to diagnosis to treatment to palliation to survivorship, and the late presentation of patients too, because there's no awareness, and cancer usually does not start with pain. So people tend to come out late, and this also impacts survival and outcomes. Our taboos, cultural taboos, backgrounds, and myths. Can you hear me?
Yes, we can hear you now.
Yes, we can hear you, sir.
Good. And then another thing is the out of pocket financing. Nobody with a standard 9 to 5 job and a 9 to 5 salary can actually earn enough money to treat cancer appropriately, like it is being done in the Western world. So insurance will help, but you know that the percentage of people that are on health insurance is very, very low. So you put all of these factors together and find out that our patients on their own side they have issues. The government and the system on its own side too has issues. So when you then add the two together, it then sets the stage for late, delayed presentation and poor outcomes. This is the slide showing the stages of breast cancer and the ones that are regarded as early stage breast cancer in quotes, the stage 1A to stage 2B. Anything beyond the 2B is regarded to be what? Either late or delayed cancer presentation. If we detect cancer early, we have a better chance at cure. How do we detect cancer early? Awareness and proper screening modalities have to be put in place. And we need to raise awareness on the disease, its sequelae, and the options of care. Let people know that it is not a death sentence and improve the outlook. And hopefully, with that, assume and believe that patients will then for examination. The important things to talk about in examination is the self breast examination. Talk about picking these things if they are very, very minute. And one of the best ways is the patient or the woman or the man themselves. After self breast examination, we can talk about clinical breast examination. That is coming forward to the health sector, to the healthcare provider, whether the nurses or the doctors, for some form of breast examination. And radiologically, we have the mammogram, the breast ultrasound, the breast MRI, and then pathologically, you can do a biopsy of the breast. African patients are younger, and the young group patients, if we look at the family structure in Africa, is such that the family unit, at the family unit, the young mother is the driving force in the family. So if the driving force is afflicted with a chronic disease that will almost most likely result in mortality if not properly treated and if does not present early, we then see that the family unit is then scarred. In a lot of families too, I dare say that women are the breadwinners too these days. So aside them just being the fulcrum of care of the children and the family unit as a whole, they're also economic providers. So this particular type of cancer really hits at the center of family socioeconomic and health indices of this category of ladies. In sub-Saharan Africa, the average age to breast cancer is between 40 and 45, 40 to 50, while in the Western world, the average age is 55 to 65. So at 55, 65, a woman has done a sizable amount of or accomplished a sizable amount of what she's meant to accomplish as a woman, as a mother, as a wife. as a family economic provider. But at 40, that's when you hit the pinnacle and need to actually be there for the family, provide for the family, guide the family, and take care of the family. So it's like a two double-edged sword. The woman is being afflicted by the disease, and then the family is also afflicted. So the woman is battling with physiologic, pathologic things. The family is battling with socioeconomic and mother daughter issues, mother son, mother economics, and mother wife economic things in the family. So early detection of cancer or its precursor can result in a less radical treatment and obviously improve prognosis of some of these cancers, particularly breast cancer we're talking about now. And less radical treatment for early disease is ultimately less expensive, recovery is faster, and the family unit that I'm upping on is less disrupted, convivial family wise, economic family wise, and all of that. And screening also reassures those with negative disease. This is late stage disease in a lady, and then the slide of early stage I don't have because we rarely see patients with early stage. And indeed, the patient with early stage disease, the pictorial representation of it on the breast is usually a normal looking breast, as opposed to the distorted anatomy of a advanced breast cancer. Mammogram is very important. It's a skillful, it requires a skillful interpretation to localize and diagnose lesions that are not palpable. Once you can palpate a lump in the breast, that cell, if it is cancerous or not, has divided at least 25 billion times to then make it advanced disease. So the aim of early detection is to pick lesions at the point where they are what? Impalpable. But the tragedy again is that when these lesions are impalpable, the mother is running the family unit, running the economics of the family, the economics of the society, and playing the mother wife roles to her own disadvantage. She keeps postponing the time to go see the doctor for the clinical breast examination, and she rarely remembers to perform the what? The self breast examination. She's struggling economically. She cannot have money to do a mammogram. She then says, "This breast pain or this funny breast look, I will attend to it in the coming months." By which time it then becomes what? Advanced disease. It is recommended that screening every 1 or 2 years of women older than 50. And for younger circumstances in this Africa, shorter intervals and a younger age is then advised. So I would say that in Africa, because the peak age is between 40 and 50, we should then screen once the patient is about 35 and then screen all the way through the 40s and 50s. In Nigeria, again, the most frequent malignancy is in females and it is breast. And 9 out of 10 times, patients present an advanced stage. We have a younger age group in the West, and the implications are essentially in deciding early detection program. Breast self-examination or self-breast examination and breast awareness, that we can consider them as being part of whole body awareness, and this might then help in reducing the incidence of advanced stage presentation. The WHO, World Health Organization, has determined that only self-breast examination can provide early diagnosis of breast cancer in many parts of the world, because not everybody has access to mammograms or breast ultrasound scans or breast MRIs, but everybody has access to each of their own breasts, and they can stand in front of a mirror and do a self breast examination. And if anything that looks out of the ordinary is discovered or found or felt, they can then escalate to a healthcare provider, not only a doctor. If a properly trained nurse can also assist with a clinical breast examination before escalating to either a mammogram, a breast ultrasound, or a breast CT scan. The impact of early detection summary is that we have health impact, we have social impact, we have economic and financial impact, and we have a long-term survival and quality of life. In a circumstance where people present early with breast cancer, survivorship is a big thing. That's the fourth bullet. Because you then have patients, you then label breast cancer survivors, who you then have to follow up for at least 15 years of their post-treatment stage to be sure that there's no recurrence of metastatic disease in any other part. And then quality of life is unequivocally better because you don't do caricature surgeries, you don't do demeaning procedures. Removing people's breasts on the guise of treating them is important and is palatable, but it's because we are not at the other end of the stick. It's convenient to just sit in the chair and say, "Oh, madam, you need to have a mastectomy," which is removal of the entire breast for reasons of this. But I dare say that the reception on the other side is usually very, very difficult, tedious psychologically, and then you're also then spending money to mutilate your body on a disease that you do not know whether you will survive because you have not presented early. So if a patient presents early, there's no need to talk about mutilating procedures or mutilating treatments. That's them surgery, radiotherapy. Patient can have a simple wide local excision, have a maxillary sampling, and if all negative, the quality of life and outcome is the same thing exactly with if you then do mutilating surgeries for early breast disease. So the aim is to always get the disease early. And in and around that, they don't have to spend so much money to treat themselves, and they spend the money and see a result, desired results, outcomes on the treatment of early disease. So there's no loss of self-esteem. Social impact is there. And because there's little downtime, there's no pressure on the health system, and the patient too feels better. There's no need to believe that if I don't have chemotherapy, I won't be alive, and all the side effects and all of that will get put at abeyance. This slide shows some cancer timeline and sojourn time. To the far left is when the disease is occult, that is impalpable. In the middle is when it becomes palpable, and then by the time it moves to the far right, it becomes clinically evident disease with either metastasis or distortion, as the picture earlier shown. This is the breast cancer continuum slide again. Talks about pre-malignant part of the disease, the invasive part of the disease, crossing over to the micro metastatic disease, and then becoming detectable and either metastatic and then resulting in death. So if we can get the patients when they are at the high risk or when they're even normal, which is a patient that's even started doing breast mammograms, maybe yearly, and presents to the health practitioner with it, you cut the patient at the normal stage, the premalignant stage, and what you can pick. That makes it very easy. You become conversant with the patient's results, the patient becomes conversant with how her breast feels, and then the chance of picking the disease when it is still in situ and not invasive, is certainly higher. So we can then prolong the disease itself, the quality of life, and reduce the treatment. We don't go to palliative treatment, we stay in active treatment with the goal and aim being what? Cure. So the slide is self-explanatory. We need to pick the patient at the high risk stage minimum. By the time we're picking at in situ, we already have disease. The disparity between the overall survival of breast cancer between high income countries and the low and middle income countries has been majorly attributed to the high rate of diagnosis of early stage breast cancer in the ICS, with about three-quarter and a fifth of the total breast cancer patients diagnosed with early stage breast cancer in the ICS and LMIC surviving, respectively. And we have found out in our own study that if patients present early, we have about 72% survival at 5 years. And if you look at it, it then means that if we can narrow the gap in terms of the standard and quality of health care available, that 14% will be easily attainable to then meet up exactly with the 86-88% quoted in the high income countries. Or even if we don't meet up, we then know that it will be because of tumor biology, which means that we may have a more aggressive disease than theirs abroad, because theirs will be postmenopausal and our predominant cohort will be premenopausal patients. Thank you very much. This is the synopsis I have as regarding early detection and the chances of us bringing out a better outcome for the patients. I'm told to leave the remaining time for questions and answers. Thank you.
Okay, thank you very much, sir. We we are so happy you shared this with us. Please, guys, I want you to thank our consultants And yes, now it's time for questions and answers. And so what? All right.
Yeah, good evening, ma. Thanks for the
Good.
program and all. My question is, are there foods that causes this breast cancer?
Okay, food that causes breast cancer is okay. That's the question.
Good evening, everyone. And
Good evening.
yeah, good evening, everyone.
Thank,
And good
good
evening,
evening.
sir. Thank you so much for that lecture. I want to ask, is there a place of sensations um in for towards in detecting breast lumps? Like before breast lumps begin, is there a place of having maybe funny feelings or funny sensations in the breast or something that could point out to the fact that okay, something strange is about to happen in this breast. I don't know if my
Okay,
question is
thank
clear.
you very much, Ma.
Thank you, sir.
So can we have Miss Joy unmuted now?
Good evening, everyone, and thanks to the consultant for that presentation. Though I'm driving, I couldn't really focus much on the topic, but I have to park now to ask my question. If a person has done a surgery to remove a lump from the breast, is there any need to be worried? The lump was tested as a non-malignant at that time when the lump was removed. Is there any need to be worried that anything could happen?
Okay, okay, thank you very much, Ma. Questions noted. I think we've covered those that raised their hands now. So I'll be handing over to the consultant to take these questions. Sir, will you have me repeat them or you noted them?
Yeah, just recap them for everybody's
Okay.
benefits. I have
So,
them, but
okay.
you can
The
recap.
first question is that are there foods or yes, are there foods that cause breast cancer? I think when we answer that, then I'll go to the next one.
Okay. So, my dear Lawal, that's Moshuro Lawal. Thank you for the question. Thank you for being attentive. Um, there's no cause and effect between food and breast cancer yet, none to our knowledge. By cause and effect, I mean that we all know that if you get bitten by malaria, parasitemia, and all of that to follow. So that's what I mean by cause and effect. If we're exposed to a patient that has hepatitis and we are not protected, maybe vaccinated, the chances that we'll contract hepatitis will occur. That's cause and effect. But we don't have any food or meal that once you eat it, it will then result or probably result in what? Breast cancer. So no, there's no food that is directly related to breast cancer. However, if you then move broadly to food generally and cancers generally, there are some particular meals that may be related to some particular cancers. I know that in East Africa, where the level of spice eating and garnishing of their food is very, very high. I mean, Kenya, um, Ethiopia, Sudan, they're high level, they put a lot of spices in their meals. They are prone to a lot of oropharyngeal cancers. I can talk about that. But you know that if you take too much of them calorie containing meals too, it results in obesity. And obesity is a risk factor for cancers generally, but we cannot ascribe it particularly to just breast cancer as the question supposed. I hope I've been able to answer your question. Thank you.
Okay, sir. Thank you very much, sir. The next question is there a place of feeling some sensation or before breast lump begins? Probably like the way you feel, then you know breast lump is coming or something.
No, no, no. There's no feeling. If it's going to come, it will come. But the idea is, if you check your breast every month, the time between the time it has come, it has not come, and the time it comes will usually be in weeks. And once a lump is picked up within a week or 2 weeks of it starting, it can only be early disease. Even if it is not malignant, it will be early. If it is malignant, it will still be early. And the chances of survival will be almost 100%, at least above 70%, rather than
Okay.
wait for the lump to start, for you to feel the lump, for the lump to destroy the entire breast before you then present to the hospital for care, by which time everything would have ended. Thank you.
Okay. Okay, so thank you, sir. The third question says that is there any need to be bothered, especially if you've had a lump removal before and it was tested as not malignant, like it is not cancerous. So
So I thank the question, the questionnaire, the person that asked the question, because she packed and then decided to engage us, which is safe. If you remove a lump in the breast and there's a generic histologic report, pathologic report that says it is not cancerous, that's good news. But you have to read between the lines. Is it a type of lump that had some hyperplasia or atypical hyperplasia in it? There are a lot of other little things that you can read in between the lines in the definite points of a benign result that gives an idea whether the lump can over time give a chance of a breast cancer occurring in that breast. That's one. And then quite a number of times, if you remove a lump in a breast, it does not mean that breast is immune to developing another lump. Not only in where the lump in the area where the lump was removed, but in other quadrants or other areas of the breast. So removing a lump and getting a benign result, pathologic, is not it does not make one immune to developing breast cancer in that same breast. So vigilance
okay,
is still always very, very key at all times.
okay. Thank you very much, sir. So I would like to take two questions from our chat box. So somebody asked, is there a right time in the month where we are supposed to be checking our breast, doing the self breast examination? Like probably maybe before your menses or something. Like is there a right time? Like is there a
Yes,
timing to
yes, no doubt there's a right time. In patients that are no longer menstruating, you just have to pick a fixed day that is convenient for you every month. In those that are premenopausal, usually 5 days after the start of your menses is the best time to examine your lump properly. Between the fourth and the seventh day, but classically the fifth day is the best time.
Okay. So I hope we all got that. Our consultant just said that, especially if you have not reached menopause, 5 days after your menses is that best time to examine your breast. Please let's note that if you are the menopausal kind of woman, you hit menopause, you can fix you can take a particular day and check your breast on that particular day. Let's say I picked on the 20th of this month, I check my breast, 20th of next month, I check my breast, like that. So I want us to really note that. So okay, all right, sir. There's still one more question I would like us to address here. The question says that um on the aspect of lumps, can you describe vividly for us what we are looking for with home testing? I think the person means the self breast examination. What exactly are we looking for? Because some still have lumps in their breast, probably as growths, I guess. Um, sir, did you hear me?
I did clearly. So what we're looking for is not only the presence or absence of a lump. There may be subtle skin changes. There may be nipple discharge. The idea is just know what your breast looks like. One, two, know what your breast feels like. At any time you are doing a self breast examination and your breast does not look like you know what it looks like normally, one, or two, does not feel like it normally feels when you examine it, then escalate to a medical health practitioner, a nurse or a doctor, for a breast clinical breast examination. So it does not end and start only with I can feel a lump, I cannot feel a lump. Some breast cancers, there's a type of breast cancer called inflammatory breast disease, inflammatory breast cancer. It does not form lumps, but it is breast cancer. So if you wait till you can feel a lump in that circumstance, then game over already. So one, know what it looks like. So stand in front of a mirror and look at your breast. The day it stops looking like it normally looks, and then stand in front of a mirror and mentally divide your breast into four quadrants and a fifth area behind the nipple and examine it, and you feel a lump, then escalate. So it's not just lumps alone. There may be skin changes, there may be orange peel look, there may be nipple discharge, there may be what looks like an insect bite. Anything out of the normal escalates immediately. Thank you.
Okay, thank you very much, sir. Um, Sir, please, sir, can we take this last one before you leave? This will be the last. So this
Okay.
person says that does not massaging the breast have anything to do with breast cancer?
The answer is no. There's no
Okay.
cause and effect too between touching the breast and not touching the breast, whether in form of
Uh,
massage, in form of nipple suckling, or in form of any way. There's no cause and effect.
okay. Thank you very much, sir. We are so happy to have you here. We are actually really, really we've learned a lot tonight. Thank you very much, sir. We are happy to have you.
Thank you, there.
Yes, sir.
Pelumi will see you in the week. Thank you.
Yes, sir.